We're actually starting, in many ways, from the wrong way around. I'm a medical oncologist and I deal with castrate-resistant prostate cancer. So that's men who have failed their primary treatment and who have failed hormonal manipulation. They're the men who previously have been thought to be at the end of the line and have been told that they have an average survival of 18 months. It's not a term I use with men that I see because I think the survival it's not a very useful average because the survival actually varies a lot. There's a very wide range. So looking at prostate cancer, as you know, it's a very common cancer and it's the second most common cause of cancer deaths. 1 in 9 men will develop prostate cancer in their lifetime, and each year about 3,300 men will actually die of their prostate cancer, not die with prostate cancer, but actually die of prostate cancer. And I think the figures for breast cancer are in about the 2,000 range. As you age, your chance of developing prostate cancer and being diagnosed with prostate cancer increases. But as you can see from this slide, you also get prostate cancer when you are young, in your 40s and 50s. And I would ask people to think of genetic mutations which make you susceptible to cancer if you do have a young man with a diagnosis of prostate cancer, because they do tend to be more aggressive and they are diagnosed earlier. So in their 40s, 50s, maybe even early 60s, as opposed to what is usual in the 70s and 80s, in particular a BRCA2 mutation or HNPCC, otherwise known as Leach syndrome. So what are our goals in terms of treatment of men with metastatic castrate-resistant prostate cancer? So their testosterone levels are suppressed either because you've had an orchidectomy or you're using an LHRH agonist, Leukerin, Zoladex, Eligard, one of those, to suppress testosterone production. And despite this, despite castrate levels, their PSAs are going up. They may have overt progression of disease, as in bony metastases or lymph nodes developing or visceral metastases. What do we actually want to do for them? I think that it is twofold, as with all cancers. We want to improve their survival. But of course, in some men who do have castrate-resistant prostate cancer, they're actually quite elderly, and that is not the most important thing. It may be that maintaining quality of life is the most important thing. However, with treatment of all cancer, we have, in fact, a twofold goal. We want to improve survival and maintain quality of life. And in order to do that, we actually need very effective treatments, preferably without a narrow therapeutic window, so that they've got side effects which are easily treated or hardly any side effects at all. So this is a slide I stole from a talk I did 10 years ago. And at that time, for castrate-resistant disease, which was then called androgen-insensitive prostate cancer, hence the AIPC, there were 2 studies demonstrating a survival advantage for chemotherapy, Docetaxel. That's, in our jargon, the TAX327 and the SWOG 9916. So 9916 was started in 1999. So the results came out about 10 years ago. And for that population of men, Taxotere was the only treatment that actually demonstrated a survival advantage and a quality of life advantage for men in this group. And for about 8 of those 10 years, we really haven't had anything else. But in the last 2 to 3 years, there's been an explosion of treatments for men who have failed chemotherapy. And now, having looked at that group, which has the poorer prognosis, we've actually brought our studies forward, and we're starting to get results for men who have castrate-resistant disease, but their symptoms aren't so severe that they do need chemotherapy, and we're actually starting to see good results in that group. So what we had was Taxotere. Mitoxantrone and prednisolone, another type of chemotherapy, didn't actually improve survival. And then we had supportive care, like the bisphosphonates, which reduced bony fractures, cord compression, pain due to bony involvement, and around the sides, radiotherapy, injectable radionuclide treatment, different type of hormones, hormonal manipulation, which was not actually all that specific. So since then, the significant trials which have impacted on the way we care for men with prostate cancer have been the RANKL ligand inhibitor, denosumab, which I know many of you use for osteoporosis. You use that once a year, whereas in prostate cancer we use it once a month. That was compared to the standard bisphosphonate therapy and found to be superior. Another study demonstrated it can delay the onset of bone metastases, but not sufficiently that I would look at recommending it as part of standard care. Last year, it was reported that a drug that once again affects the androgen pathway, abiraterone, a 17-liase inhibitor, demonstrated a survival benefit and a quality of life benefit in men who had failed chemotherapy, a group of men who traditionally have a very rapid downward path once they've failed chemotherapy, meaning that they're actually resistant to chemotherapy. So that was a huge advantage, in particular, seeing the quality of life improvement in those men. Another similar drug, once again affecting the androgen pathway, called MDV-3100, which doesn't so much block androgen production, but actually blocks its action at multiple points, also demonstrating a survival advantage in men who'd failed chemotherapy. And just this year, last week, both abiraterone and MDV-3100, the trials in the pre-chemotherapy men have demonstrated that both those drugs have actually prolonged survival in men who have not yet been exposed to chemotherapy. Following failure of Taxotere chemotherapy, there's a new taxane, Cabazitaxel, which is effective even in prostate cancer, which is resistant to Taxotere. And then we have an injectable radiotherapy agent. It's an alpha emitter, whereas the traditional agents, strontium and samarium, are beta emitters. And this alpha emitter used on a monthly cycle has also been shown to improve quality of life and survival. So we've actually almost got a sudden glut of agents which are at the moment queuing for approval by PBS. And looking at it in a different direction, we have some immunotherapy agents. We have a Provenge, which is a prostate cancer vaccine, which has also demonstrated a survival advantage in castrate-resistant prostate cancer. Now, I think it's interesting to look at these agents that I've spoken about. Some of them clearly affect the androgen pathway. Others work in a way that is independent of the androgen pathway, such as Cabazitaxel, the chemotherapy agents, and the immunotherapy agents. But one of the things to emphasize is that even androgen-resistant prostate cancer or castrate-resistant prostate cancer remains exquisitely sensitive to testosterone. And a question that I often get asked is, do I continue their LHRH when they are castrate resistant because it's not working? And of course, we haven't actually done a clinical trial to specifically address that, but the answer is yes, because the majority of the evidence is that men actually do better that way. And if we look at the trials of the androgen pathway, that's abiraterone and MDV-3100, the levels of testosterone that we're pushing down to are not those that we can readily measure in our laboratories. So yes, it is actually important to do that. So if we look at denosumab, which has now superseded the bisphosphonates in the prevention of skeletal-related events, denosumab is a RANKL ligand inhibitor. It essentially interferes with the pathway where the tumor cell attacks osteoblasts, and then you get a release of cytokines. It activates the osteoclasts, which break down bone, and in turn the osteoclasts also release a group of cytokines which in fact stimulate tumor growth. So by giving an antibody to RANK ligand, you actually cut this whole pathway short. So these men were men with castrate-resistant prostate cancer. They had bone metastases, and the question was, if we gave them denosumab as opposed to Zometa, would we prevent more pain, need for radiotherapy, fractures, requiring orthopedic intervention, and more importantly, cord compression? And we looked at whether you could give them this treatment, and did it just prevent one event, or if you continued it, did it prevent further events? And essentially the answer is yes, it does both. So these men are essentially fairly representative of most of the men that we see. They're in their 70s. They've got a good performance status. 90% of them are up and about. They can do light exercise. That's what it means by ECOG 0 or 1. And the majority of patients probably had a bit more exposure to denosumab than Zometa. And the reason for that is, I think, one, that maybe it was more effective, but secondly, a very important reason is that the bisphosphonates do affect renal function. And as you know, if you've got prostate cancer, you can have obstructive uropathy, and that plus their age group, there are multiple reasons why you can have renal dysfunction. So denosumab I find a lot easier to give because you don't have to dose adjust it with renal function. And more importantly, you don't actually damage their kidneys, so you cannot give them subsequent therapy. So it demonstrated that there was an improvement in their time to their first skeletal-related event, and also to subsequent skeletal-related events. And these were not sort of immaterial things. They were, pain requiring radiation, surgical intervention, or cord compression. There was no effect on overall survival. That is what we had anticipated. Although if you go into some of the biology, there could affect it. So looking now at abiraterone, one of the drugs that actually affect the androgen pathway, and basically what abiraterone does is that it reduces the synthesis of testosterone from the adrenals, from body fat, and from tumor cells, because it's a 17 lyase inhibitor. If you look at the pathways, all of these could be active, and this pathway of steroid synthesis also explains one of the side effects of abiraterone, which is that you can have a low ACTH level, low cortisol, which is why abiraterone has to be given with prednisolone. All the trials I'm presenting are multinational phase 3 randomized trials, and therefore they are the gold standard. And the experimental arm is always compared with a standard arm, which is considered the gold standard. Unfortunately, in this case, it's obviously placebo because we didn't have anything better. So when the data monitoring committee stopped the trial because the number of events had been reached at the planned interim analysis, and the overall survival, the primary endpoint, was positive. Men who were on abiraterone had a 14.8-month survival, median survival, and those on placebo had a 10.9-month overall survival. I think the benefits were across all subgroups. Some people thought that maybe those with visceral metastases mightn't do so well on a hormone treatment, but that's actually not true, not with prostate cancer. Some people thought maybe the more elderly wouldn't do as well, but that's not true. So if we looked at whether or not you did less well if you were further down the track, say if you had 2 or 3 lots of chemotherapy as opposed to only one cycle of chemotherapy, that likewise wasn't true. So all subgroups benefited, except maybe those who were designated ECOG 2. So ECOG 1, you're able to do light exercise. ECOG 2, you're probably confined to a chair or bed up to 50% of your waking hours. And all the secondary endpoints, looking at time to progression and PSA progression, were also significant. I think more importantly, if we look at this slide, you'll see that the placebo group actually have more side effects than the treatment group. See, a grade 3/4 side effect is a significant side effect, and the 58% of the placebo group actually reported problems, whereas only 54% of the group that actually had the active drug. And I think that that is indicative of a drug which is very active and with a large therapeutic window. And as a result of that as well, you have more people on the placebo groups discontinuing treatment. Adverse effects of special interest relate to the fact that these patients require supplementation with prednisolone because it actually stops the body's glucocorticoid production. So abiraterone acetate prolongs survival, and there's a quality of life advantage. And these findings were borne out in the most recent update presented last week at ASCO, once again across all subgroups. The other drug that works through the androgen pathway, MDV-3100, the significant difference between MDV-3100 and abiraterone is that it doesn't actually stop testosterone production as such, it actually stops action. It doesn't interfere with the glucocorticoid pathway, and that means we don't actually have to give patients prednisolone, which is a big advantage, because when we give patients prednisolone, in a way, we're actually creating another problem, because you have to get the dosage right, and over time, you actually end up suppressing adrenal function, and so you've created the possibility of Addison's syndrome. So MDV-3100 in the study post-Docetaxel, likewise, a very similar patient population to that which I've just presented to you with abiraterone. And once again, MDV-3100 showed an improvement in median overall survival in men post-chemotherapy from 18.4 to 13.6 months. And with the secondary endpoints, they were also significant. So moving on to a more toxic treatment, to chemotherapy, once again in men who'd failed docetaxel. And the reason we focus on this is that we look at that particular patient group and we find treatments that work, and when we find that they do work, we actually bring them forward in the whole cancer story and see and test them again, because you cannot assume that something that works in very advanced disease will work in early disease. And I can give you examples of that, such as Avastin with bowel cancer. So everything that's done in cancer treatment really needs to be tested properly in phase 3 clinical trials. So these group of men were randomized to Cabazitaxel, which is a new sort of taxane, which works when the docetaxel resistance develops in the cancer cells. These patients were just a little bit younger, about 67, 3 years in their median age advantage. They also had a good performance status. 90% were ECOG 0 or 1, very similar to that abiraterone group. Maybe a few more had visceral disease, but they were very, very heavily pre-treated. If you sort of look at this slide with the amount of chemotherapy that they'd previously had, I can assure you that they were very, very heavily pre-treated. And then the other thing that this slide shows is that 70% of those men had actually such aggressive disease that the prostate cancer was growing while they were receiving docetaxel chemotherapy. So they are genuinely, a resistant, aggressive bunch. And when we looked at the results, there was clearly an overall survival advantage for men receiving Cabazitaxel. A median overall survival of 15.1 versus 12.7 months. And more importantly, with that improvement, a lot of men actually felt better. Provenge, or Sipuleucel-T, is a immunotherapy it's actually quite awkward in terms of giving it, and you do need to have the laboratory about 12 hours from you. So at the moment, we don't in fact do this in Australia. But the patient's blood is taken through leukapheresis, and then it is actually sensitized by presenting it to T cells and dendritic cells, and it's incubated with a fusion protein and reinfused. Very costly, 100,000 for a 4-month survival advantage. You can understand why the PBAC are thinking 2, 3, 4, 5 times about any of these treatments. The Sipuleucel has gone through 2 phase 3 studies. Both of them have shown a survival advantage. And the mechanism of action is probably not entirely clear-cut. We haven't elucidated it yet. Now, I've talked like we actually understand the exact mechanism of action of all the drugs that I've spoken of, and we actually know that that is not the case. There's a lot that we don't understand. And it's likely that prostate cancer, like breast cancer, actually has multiple different subtypes. And as we're doing these studies, we're collecting tissue and blood so that it can help us to better refine which patients we should treat with the different drugs. This immunotherapy agent also works well after chemotherapy, and that's something which is unexpected to some degree, because there used to be a thinking that chemotherapy destroys the immune system. I think we actually have a better understanding now that chemotherapy sensitizes the immune system, it destroys part of the immune system, and it actually improves other parts. So, and that's a common question that you get from patients. Won't chemotherapy destroy my immune system? And I think we can tell them that it's a lot more complicated than that. Ipilimumab, which you probably have heard as a treatment for melanoma, once again, is an immune treatment drug. As cancer develops, it creates more of a molecule called CTLA-4. CTLA-4 binds to T cells and basically paralyzes them. So if you can mop up the CTLA-4 with Ipilimumab, which is an antibody to CTLA-4, you free up the immune system to actually attack the cancer. And the important thing is when we are looking at drugs and how they treat cancer, we have to be careful with what we call surrogate markers. For example, in a lot of these trials, they've been very hard to conduct because people have been focused on PSA. And we know that the chemotherapy drugs actually don't work on PSA. You do sometimes get a PSA fall. You get a very dramatic PSA fall in 50% of patients. But there was a study presented at ASCO this year demonstrating that PSA is a very poor surrogate for overall survival in men who are treated with chemotherapy for prostate cancer. And of course, you can actually get a massive PSA rise before it actually falls. And in the immune treatments, that is actually an issue. This slide here actually shows you what happens if you look at a lesion. So when someone is on an immune therapy, this is the original lesion. This is after he starts to be treated, and you can see there's actually an increase in the lesion. You'd look at that and you'd say, that patient's progressing. So in terms of like prostate cancer, you might look at their prostate and you say, he's got increased obstructive symptoms, it must not be working. But it depends on the time frame, and it might just be that there's a rush of immune cells into that. However, if you look at him further down the track, it's clearly responded. Hence, the whole area, I think, you've got to be very careful in terms of saying that someone is progressing, and I guess that following the clinical trials protocols is crucial. Alpha-radin is an alpha emitter. It's very easily given. It has to be flown halfway around the world. In the end, it's about an 18-hour trip. There's only one place that makes it at the moment. And we were also involved in this trial. Very well tolerated. And once again, it has shown a survival advantage and a quality of life advantage. Once again, wide therapeutic window, showing that those who actually received the drug had fewer side effects. This is grade 3 and 4, 51 versus 59%, fewer side effects than those who did not. And of course, if it's being treated and you don't have side effects, you want to continue. So from having nothing to treat a man who had failed taxane chemotherapy, we now theoretically have a lot of agents. And we have a lot of very exciting new agents that look extremely promising and that we need to test. These are some of those agents, but what is it that you actually have to do if you've got a man with castrate-resistant prostate cancer? I think, one, yes, you do need to continue their testosterone suppression. Do you need to start bisphosphonates or anti-resorptive therapy? Not necessarily. It depends on on their bulk of disease. I think early referral is important. There are different subtypes. Some men progress very quickly, some more slowly. Others, the pace of their disease actually changes. Once they've had chemotherapy, often the pace of the disease is faster because they're at the more accelerated end. And I think keeping in touch with a medical oncologist in that case is actually very important.